Let's talk about syncope, also known as fainting or passing out. Syncope is a temporary loss of consciousness associated with a loss of postural tone and a spontaneous return to baseline neurologic function. Pre-syncope is a sense of lightheadedness and near fainting that often precedes syncope. Syncope itself is easy to pick up on. Patients will generally say, "I think I fainted," or "I don't know what happened, but the next thing I knew, I woke up on the ground." It's important to distinguish pre-syncope from vertigo, which is a sensation of room spinning, swaying, or tilting discussed in another episode. Generally speaking, in order to stay awake, alert, and cognizant, your brain needs to be nourished continuously, and any interruption in the normal blood flow of oxygen or glucose to the brain can result in syncope. Glucose is the easier of the two to manage, so let's start there. Your brain uses glucose for a significant amount of its energy needs. When glucose levels are low, the brain ceases to operate and syncope may result. Hypoglycemia can also cause seizures, fatigue, or paresthesias. Hypoglycemia is a diagnosis that can be confirmed and cured within seconds. In fact, it's standard for ambulance crews to check their patients' blood sugar levels and treat for hypoglycemia before they even make it to the hospital. Even then, many physicians still forget to check their patients' blood sugar levels. The other major component needed for ongoing brain function is oxygen. Therefore, causes of hypoxia and hypoxemia should also be considered when working up syncope. The more common causes considered in the ED include pulmonary embolism and anemia. Chronic problems that cause hypoxia or hypoxemia, such as CHF or COPD, can also cause feelings of lightheadedness, but usually the main complaint is that of shortness of breath. Lastly, we come to blood flow, probably the most difficult category to diagnose. Glucose can be checked with a glucometer, anemia can be screened out with a bedside hemoglobin meter. With pulmonary embolism, there are many ways to risk stratify a patient, and ongoing hypoxemia can be screened out with a pulse oximeter and a physical exam. However, when you consider blood flow, you realize there are all sorts of different things that can go wrong. Any system of flow requires three components: the pump, the pipes, and the fluid. First, considering the fluid, for an adequate blood flow, you need an adequate volume of blood. Blood has two components, the serum and the red cells. A low volume of serum is often referred to as dehydration. The fainting it causes is generally termed orthostatic syncope and can be fixed with fluids. Inadequate red blood cells brings us back to the topic of anemia, which we just covered. However, you must also consider the loss of both simultaneously, which can be termed acute blood loss, which may initially present with normal hemoglobin. Regarding acute blood loss, there is one situation that isn't always so obvious that every good doctor should keep in mind: the case of the young female who faints. Until proven otherwise, this patient has an ectopic pregnancy which has ruptured, now causing a massive bleed into the abdomen. In many cases, the patient doesn't even know that she is pregnant and definitely will not know that she is bleeding intraperitoneally. The next component for adequate flow is an adequate pump, the heart. Think back to your cardiology lectures. For everything that can decrease cardiac output, there's a lot. However, in the ED, we are most concerned about acute coronary syndrome and arrhythmia because they are the common causes for sudden death. The last component to consider when thinking about adequate flow of any system is the pipes, or vasculature. Recall that systemic resistance is a huge determinant of blood pressure. When your blood pressure drops, you will no longer be perfusing your organs, such as your brain, with the nutrients they crave. We've already considered several cases of sudden drops in blood pressure like acute blood loss or acute coronary syndrome, but let's focus now on the causes of decreased vascular resistance. Vascular resistance is regulated by your sympathetic and parasympathetic nervous systems, as well as some hormonal inputs. Dysregulation occurs when there is an inappropriate balance in these systems. This is what happens in vasovagal syncope and micturition syncope. Vasovagal syncope is the most common cause of all syncope and is a catch-all term for any cause of a parasympathetic surge or a sympathetic crash that results in syncope. Micturition syncope is a special type of vasovagal syncope that occurs with urination, or micturition. In general terms, the patient will really have to go to the bathroom, thereby resulting in increased sympathetic tone. After or during urination, they are so emotionally and physiologically relieved that their sympathetic tone disappears, leaving only the parasympathetic tone, resulting in a decrease in systemic vascular resistance and ultimately syncope. As with the majority of disease, the elderly are most susceptible. You might be surprised after only a few days in the ER how many elderly patients are found down in the bathroom. Lastly, while several causes of shock, including anaphylaxis and sepsis, cause decrease in systemic vascular resistance, we generally don't consider these causes of syncope, as they rarely spontaneously regain consciousness when they reach the point of anaphylactic or septic shock.